I'm Rebecca Brown. I'm a pediatric endocrinologist at the National Institute of Diabetes, Digestive, and Kidney Diseases. And I'm here today to talk to you about lipodystrophy, really to educate hepatologists about this diagnosis. So when might you consider the diagnosis of lipodystrophy in a patient who walks into your office with steatotic liver disease? Well, there are some red flags that might alert a hepatologist to consider this diagnosis. This includes the presence of metabolic disease like insulin resistance, diabetes, fatty liver disease, dyslipidemia, that are out of proportion to the degree of adiposity that the patient has. So a lean patient, for example, who has these conditions that we more commonly associate with obesity. On physical exam, you should look for either a generalized or regional absence of subcutaneous fat. And often on family history, there may be either an autosomal dominant family history, particularly for patients who have partial deficiency of body fat, or perhaps a history of consanguinity in patients who have a more generalized deficiency of body fat. So how is it that patients who are missing body fat with generalized or partial lipodystrophy have fatty liver disease? Well, the metabolic complications of lipodystrophy stem from the lack of adipose tissue. Adipose tissue is an essential organ for maintaining metabolic homeostasis. If this deficiency of body fat is severe, this can cause low levels of adipocyte-derived hormones, specifically the hormone leptin. And low circulating leptin in patients with generalized lipodystrophy who have very low leptin is sensed as a starvation signal in the hypothalamus. And this produces the hyperphagia that's an associated symptom of lipodystrophy. When patients consume excess calories, adipose tissue normally is providing a buffer that allows us to safely store those excess nutrients and release them in times of need. However, in patients with lipodystrophy, because excess calorie intake as a result of hyperphagia can't be stored in subcutaneous adipose tissue, because patients lack subcutaneous adipose tissue, this nutrient excess is instead stored in ectopic locations, such as the liver and the muscle. Now, the liver and the muscle are very important insulin target tissues. And when you accumulate ectopic lipids within those tissues, this leads to insulin resistance through complex and incompletely understood mechanisms. And insulin resistance can further exacerbate liver fat accumulation by stimulating de novo lipogenesis. So it's a bit of a vicious cycle. So what additional clinical signs or symptoms in patients might raise suspicion for having a patient with generalized or partial lipodystrophy? So I mentioned either generalized or regional absence of subcutaneous fat, but where exactly should you be looking for those absences of fat, and how should you look for them? So it's critical to undress patients. The most common depot that's affected by adipose tissue loss in patients with lipodystrophy is the gluteofemoral depot. So we're talking about the buttocks and the legs. And you can assess fat in these different body regions through simple clinical exam with skin folds. You just gently pinch up the skin and see how thick the layer of subcutaneous fat is underneath the skin. And this normally varies based on body part. You can use yourself as a healthy control to get a sense of what normal skin fold thicknesses are. In patients who have a regional or generalized deficiency of body fat, the skin folds, at least in some parts of the body, should be extremely thin, like a normal skin fold on the back of your hand in a lean person. In addition, as I mentioned, patients with lipodystrophy will often have metabolic disease that's out of proportion to the severity of their adipose tissue. And so this could include looking for acanthosis nigricans as a sign of insulin resistance, patients who require very high insulin requirements in the context of diabetes, patients who have a history of high triglycerides, especially those who have suffered from acute pancreatitis, or low HDL cholesterol. So what genetic and metabolic tests are needed to make a diagnosis of lipodystrophy? Well, the short answer is none, really, because lipodystrophy is primarily a clinical diagnosis based on the regional or generalized deficiency of body fat. But this is associated with dysfunctional adipose tissue, which is evidenced by metabolic disease. So the evaluation of metabolic disease in a patient with suspected lipodystrophy should typically include measurement of fasting insulin, hemoglobin A1C, fasting lipid panel, and some evaluation of liver health, including, for example, liver ultrasound or FibroScan. Some cases of lipodystrophy are genetic, and in that context, genetic testing may be confirmatory, but it's not required to make a diagnosis. And some cases of lipodystrophy are not genetic, and therefore genetic testing will be negative. So, what's the role of metroleptin or recombinant human leptin to replace missing leptin in patients with lipodystrophy? And specifically, what is its role in reducing liver fat and metabolic complications? So, I want to caveat this by saying that metroleptin is not approved for treatment of liver disease in patients with lipodystrophy. It's been shown to improve insulin resistance, diabetes control, and dyslipidemia, specifically high triglycerides. However, clinical trials that were done with metroleptin, particularly in patients with generalized forms of lipodystrophy, have shown that metroleptin does reduce liver volume and reduce liver fat. It also reduces liver inflammation. But importantly, the data to date have not supported a role of metroleptin in reducing liver fibrosis. So what can hepatologists do to effectively screen and manage patients with lipodystrophy? Well, really, the first key step is just to think about the diagnosis. It's not a diagnosis you're going to make unless you think about it first. Once you think about it, then you want to perform a careful physical exam, looking for abnormal fat distribution, asking about family history, considering genetic testing. And the management of liver disease in patients with lipodystrophy is really going to be quite similar to obesity-associated steatotic liver disease. Referrals to genetics, endocrine, or other subspecialties based on the patient's comorbidities are appropriate. So just to wrap it up, you should think about a possible diagnosis of lipodystrophy in a patient who presents to your clinic with steatotic liver disease, who seems to have metabolic disease that's out of proportion to the severity of their obesity. Lipodystrophy is a clinical diagnosis, and a good physical exam looking for abnormal body fat distribution is an essential part of making the diagnosis. That's it, and thank you very much for listening.